اتفضل يا دكتور محمد.
بسم الله الرحمن الرحيم. Thank you very much for this kind invitation. Uh, Very grateful to be with you today. Today we are talking about CRT response. Our talk today will be divided into three main parts. What is meant by CRT response and how to measure. Second part is how to identify patients before implantation that are most likely won't benefit from CRT. And lastly, we'll talk about possible management of these problems. Uh, I remember very well when I first started reading, when I was a very junior cardiologist, about heart failure, and I read it. It has a 5-year survival rate of some number, and I was struck because 5-year survival was used only with malignancies. And until very recently, this is the case. Advances like drugs and CRT device in the early 2000s was a very big addition in management of heart failure patients with reduced ejection fraction. However, after all these techniques, still up to 30% of patients don't respond well to CRT device. Plus, there are variable definition of CRT response. First, to add to the lecture of Dr. Iman, implantation is a very important part in response to CRT. After you select the patient well, do your best during implantation to get a good vein and a good ECG. Then we come to CRT response. We all know the patient who has responded well after CRT implantation. And this patient becomes very good responder. His complaints are better, no hospitalization. But some patients don't show this. However, these patients usually are the super responders. So we shouldn't consider response as either a yes or no question. It should be dealt as a continuum. And in the following slides, we'll try our best to put an objective measurement to this response. This is needed to identify with the patient if he responded or not, to discuss with the patient possible improvement and possible plans to further this improvement. Besides, response to CRT may not be evidence except after few months of implantation. We will use 4 criteria to measure CRT response: quality of life, ECG, remodeling parameters with echo and the clinical outcomes. So first, with quality of life, we use some questionnaires like the Minnesota Living Health questionnaire of 21 questions giving a number, and this number defines the quality of life of the patient. And we need this score to get lower. Lower means better in these cases. We need the 6-minute walk test to increase after CRT to say it's improved. And we need the peak oxygen consumption and other exercise parameters to increase. These are the quality of life measurements. Besides NIHA class, if the patient NIHA class gets better, he's improving. The echo is very straightforward, almost the most straightforward part. Usually we define response with increased ejection fraction about 5%, decrease of left ventricular systolic volume and systolic volume more than 10%, and improvement in functional mitral regurgitation. The ECG, response to ECG is usually defined by narrowing of the QRS by more than 20 milliseconds or 20% of the baseline. And the outcome, it's difficult to measure outcome in single patient as mortality, but you see with hospitalization and clinical improvement. Another important point, the use of biomarkers. Actually, till this very moment, there is no consensus about the use of biomarkers either to predict response or to detect response. Here are 2 papers, examples of papers. This is 2025 and one in 2023 that used several biomarkers to detect response and the prediction of response to CRT, but the conclusion was that no improvement or no correlation with most of these biomarkers. And many of these biomarkers are very strange names to our ears, especially for those who are devoted to this. This is another paper, and I get this to show you the number of biomarkers that are used in these settings. Some of them give promising results, but still, so far, no consensus and no clear guidelines about use of these biomarkers to detect response or to predict improvement in these patients. So we do our best in selecting the patients, and some patients are expected to not respond. Who are these patients? These patients usually patients with very rapid atrial fibrillation uncontrolled will not respond. Patients with heavy BVC's burden, 10% or more, will not respond to CRT. Patients with QRS, either narrow QRS, even with dyssynchrony in echo, or patients with non-left bundle morphology won't benefit from CRT. Patient with ischemic etiology shows a less response than patients with direct cardiomyopathy. And this is mainly due to scar burden. So in some cases, if you need, some may use cardiac MRI before to assess the area of scars to detect areas of implantation. Patients with very advanced kidney disease may not even tolerate the implantation, and patients with very poor right ventricular dysfunction may not respond. So these patients, you should be very clear when you are discussing with your patient or you're discussing with yourself the options of treatment, and beware of CRT in these patients. So how to treat this? The first important is you can't do it yourself. You need a teamwork of you and your specialized heart failure and specialized cardio imaging. And the first step is optimizing therapy. CRT is an add-on treatment to therapy. So if the patient is not receiving proper medical treatment, do it. If you can maximize the dose, do it. Use new drugs like sacubitril valsartan, which was not evaluated in early CRT studies, and manage arrhythmias of atrial fibrillation with either good rate control, good rhythm control, or even evinodal ablation. Manage BVCs, either medically or ablation if possible, and use all you can to optimize programming, especially with VV interval, AV intervals, and the new devices give you a lot of features that can do it for you to get the most beneficial result. Some of the future perspective in this era, maybe we have two promising options. The first is conduction system basing. And I mean conduction system basing here as a head-to-head with CRT. And I think this is going to increase. So far, guidelines recommend this sometimes if you fail to put a CS leads. But I think with increasing practice and availability of conduction system basing, this will replace CRT in many cases, and there are many promising results in studies. So, but still not to go to guidelines as a main option. But I think many of our professors are starting to doing this nowadays. The second hope is in artificial intelligence. And I think any talk now or any conference without talking artificial intelligence will not be enough. But here it's actually starting to do something. The main, in a nutshell, how they do this? They get, for example, very big data. What's the big data? All the patients who implanted CRT from start of CRT, and give all the data of these patients to the computer, adding all the follow-up to the computer, define response, and the device alone will learn who will benefit and who not. And if you have a patient, you can give your data to the device or the module, and he tell you what is the probability of response. But this is still in the future. I made this lecture. I wasn't sure about timing, so I made it to fit. Thank you.